All right, we're at the AAE meeting here with Dr. Adham Azim, who just had a wonderful presentation here on the new XP-4D. This time we're upgrading from 3D to the 4D, right, Adham?
That's true.
Well, first, thank you so much for joining me here. And let's talk a little bit about this new innovation. So we've moved from 3D to 4D. Give me a little bit of an overall background and the impetus.
See, I'll tell you, Ali, it's not like we're moving away. It's trying to solve a problem. You know, we were just speaking earlier before this, and today I think I was told yesterday there's like 450 rotary file system on the market. It's not like, do we need 451 to come on the market?
That's the answer.
That's the answer. We were just waiting for this one. So, no, again, I'm addressing this from a need. I think we are really improving, our instruments are improving very well, the manufacturing is improving very well. And now it becomes a question of, can we benefit from these improvements by making ourselves more efficient? So the thought is coming from efficiency. There has been a lot of files on the market with the primary focus is, they say, oh, we are a single file system, or you can. But if you really look into the details, it was like, yeah, you will have to use hand files till size 15, and then you have to use these glide path, and then you use our single file system, right? So for me, that is not solving the problem. I think the key problem for most of clinicians is actually transitioning from a size 8 to your rotary file.
Right.
So can we address this problem? The XP-3D, you know, I think our group has published the most on it as well. We understand the file very well. It does a good job, but it has limitations. And we found that the main limitations were related to how well it can clean the last couple of millimeters. How smooth, perhaps maybe that's the better term to use, how smooth the file can advance in a tight canal in the last few millimeters. So our data showed, our research showed, even clinical experience from other clinicians has showed the same. It seems not to be smooth in the last couple of millimeters. That's one problem. The other problem, it seems to be fitting at aperture sometimes is an issue. And then I cannot be smaller, I cannot be larger. So I'm stuck somewhere within the size that's being generated. It has its advantages. Obviously, it can touch more canal walls. And the thought started from, can I take some of these advantages and combine it with some of the advantages of our typical solid core rotary files, the normal files, how they look, you know, like most of the files. Can we kind of mix and match and join them together to achieve better our goals? And we can really reach a smoother transition from a size 8 to your master cone within a very short sequence. And it's not just about using one file or two files. Actually, the key point is, how long does it take you to use that file to reach the working length? So if I can work with a file for 3 minutes to reach the working length, for example. It's a single file, but it is not necessarily efficient. So how can we factor in efficiency with smooth transitioning, with safety? You know,
Right.
These are all elements. If we all as clinicians, we want that, right?
Right.
So it was developed from that mindset, and then it becomes, how can we change the tip to meet this demand? How we change the taper in this part versus that part? So that took us in the making, took around 3 years in the making. So it was really, I think, a well thought through process to really be able to address efficiency from the highest level, not just from it's efficient, it's one file, but it's reality, it's not.
Terrific. So you do, from what I saw in your presentation, we have a multiple set of files that try to accommodate different needs by given the kind of canal you're dealing with. So what is the algorithm for these 4 canals to be, or rather 4 files to be used efficiently, as you are mentioning here?
So the goal here, and I want to start maybe by talking on canals that we struggle with the most, the tighter one, the smaller one, right? So if I get a size 8 loose in the working length, we can transition from 8 to the starter file, which has a tip of 20, starter file. Some clinicians prefer to finish somewhere in the 2003, 2004. We have matching cones that can go after that file. But my preference as a clinician is to go to size 30. This is where I can, you know, disinfect to my expectations. And so it would be a 20, a 30, and then a matching cone with a 30. So the system has 4 files in total, 20, 30, 40, 50. We call them starter, standard, medium, and large. And each one of them come with its matching cones that have been customized particularly for the system. It has different tapers in different size, but on average we say it's like within the 0.3 taper range. And if you want to go bigger, if you have a big, large canal, let's say, you can go to 40 and 50. But, and again, this talk is going to be heard by specialists, going to be heard by also generalists. So the safest sequence would be go 20, 30, 40, 50. But if I'm dealing with a canal that's on the large size, I can just go 10 hand file 30 or 10 hand file 40. Mm-hmm. And that's how we can be super efficient. And we can focus on the part of treatment that matters the most, which is let's irrigate, let's use our irrigants, let's disinfect the canal better, right? Mm-hmm. So I find mechanical to be means to an end, right? Mm-hmm. So I don't need to be using a very lengthy sequence to achieve that goal.
So it ends up being a couple of hand files or so, or maybe just one, like an aid to get some type of patency and validate a path.
Correct.
Then you're using your starter to kind of create and enlarge that path to a small size. And then depending on the size that you want, you'll end up with the corresponding 30, 40, or 50 based on the canal that you have.
Exactly.
It's fairly streamlined. And then you said then that the cones that you have to fit those are variable taper then in order?
They are customized because what we learned also from the XP Shaper experience here is the recommended gutta-percha at the time was a 3004. But we learned that the XP Shaper doesn't give us a standardized taper. So that created also issues that it can fit sometimes and sometimes it does not. Mm-hmm. But what we learned from this is let's use something. So the design of the file come with using an 03 taper in the first 4 millimeter, 4.5 millimeter. Then there is no taper in the file, but there's a loop that's going to give us that kind of expansion, right? And when we did all the geometry assessment, it can fit 03 till a bigger portion of the canal, but towards the orifice, we want to keep the pericervical dentin really maintained, so it starts getting smaller. So if I have a canal that is 8 millimeter length, is very different than if you have a canal that is 15 millimeter length. So that depends on the route you're working with. That's why we want to factor that with the gutta-percha. So I would say, please use the recommended gutta-percha that goes with the system rather than, it's 03, I'll just use any 03. You may see struggles that you may see it's not fitting as your expectations. So we really worked on that. I know the company want to keep it a little bit on the, they don't want to share too much on that, but the reality is it is just adjusted right to our system.
Okay, terrific. So then you feel that by using the system, as you have indicated, that cone fitting would not necessarily be a challenge, because that was usually the issue with the XP-4D, right? So you think that now then this would be able to address that issue of better cone fitting?
100%. We have zero issues. Again, when I worked with it, zero issues. We had our KOLs trying it, zero issues at all. Everybody said it does exactly as claimed. The cone is going to fit exactly what it is. What I recommend with this system is that we are instrumenting till your working length. You don't need necessarily to stay on the shorter side. You can go to your working length. Don't attempt to stay short.
Excellent. And then so length control, given the fact that the file is moving, is not an issue either. You've managed to get the stopper to the place. Do you recommend to go to the working length that you recommend to essentially measure with your hand file, right?
Correct.
And then keep that on your rotary file. Do you recommend to go to the full length, a little bit short of it, you said again?
I would definitely not go short. I would go to the full working length. We had issues also with straightening that used to happen with the XP Shaper, especially in the first loop, and that can result in length change. By eliminating that loop, we sorted this problem as well. So there is no straightening that could happen to the instrument.
Because my understanding is that the initial few millimeters of the file is pretty much straight, so that should not be
correct. We have a standard taper, which is an 03 taper in the first 4 millimeter, and it's fully straight. There is no loops there.
Right. So then essentially the tip is creating a conventional shape, but then the top is creating the taper along with it. So that combination of creating a taper with a conventional shape adds that additional motion from the top that makes the tip also move around a little bit to get a little bit additional touching of the walls. What is the comparison in terms of touching wall surfaces between these systems?
See, I'll tell you, definitely I think there has to be some independent studies on this, but the way we thought of designing that, and that was based on previous work that we published, at the apical part of your canal, there is no need to expand our instrument much because the the canals within the apical 3 to 4 millimeter tend to have a rounded shape anyways, okay? They start to become more ovalish in the middle and coronal portion. So with that mindset, we thought, and our data that we published from 2018 showed that exactly when we compared rotary files to XP Shaper in the apical 3 millimeter, there's no difference between both. They touch the same amount of walls. But the difference starts happening in the middle of the canal at the coronal portion of the canal. So, okay, then we will put the loop to address the middle and coronal. So while I cannot say we have data to support that, I would say the thought is translated from previous work that we published.
Perfect. And so my understanding is the instrument set is being launched at the AAE
Correct.
here?
Yes.
Terrific.
Yes.
So now it's available. So people are going to get a chance to use it and get the feedback from it. But it seems to be an interesting system. If it has improvements over XP, which I originally used a lot, but I realized that at the beginning with the regular finisher was a little bit challenging to put it in the canal, especially in the back area.
Correct.
This hopefully will be able to solve that, and we'll find out. But best of luck to you. That's a terrific thing. You know, I'm a big fan of innovation, developing new products and so on, and hopefully this will solve the main problem of touching canal walls, cleaning, disinfecting, and one of the areas that's really close to my heart, efficiency.
Absolutely. So all what I can say is, if we want, and again, that's my opinion, my biased opinion, obviously, and I don't think that we're never going to stop making files. There will definitely be number 452 and 453 very soon. Okay, but if we're talking about how to be efficient, I believe clinicians can see the difference in how to be efficient. I have one recommendation would be, if you've been using something for so long, you should not expect that you will try something different today and suddenly you're going to fall in love with it. You have to give yourself a chance. I think the people who used the XP Shaper before will be the easiest to transition because, again, they understand the concept of the expansion. They understand the concept of working at 1,000 RPM. But for anybody who was using standard rotaries before at a 250 or 300 RPM, please give yourself a chance to digest the higher speed and the flow and how the file operates in the canal. Do not expect, regardless of your experience, respect all the experience that you had before, but your muscle memory, your hand is so used to certain push and to certain way of operating instruments, which is different for this file. So the way it has to be operated cannot be short pecks. It has to be long strokes, very long strokes, complete relief of the instrument. Let the file drive. You are not the driver anymore. Let the technology do the work for you, and you would take the back seat and enjoy the ride.
Terrific. Well, like anything, it has its own way of doing things, and it's important for people to read instructions, follow the directions in order to get the most out of the instrument. Terrific. Best of luck to you.
Thank you, Ali.
And hopefully I'll see you soon again.
Absolutely.
The meeting.
Absolutely.
And from the AAE meeting in Boston, 2025, Dr. Adham, Azim.
Thank you.